Good afternoon and welcome to the latest in the series from the Innovators Workbench. My name is David Cassak from In Vivo magazine, and it's a real pleasure tonight to introduce this particular interview with John Simpson. You know, it's been one of the interesting things about this series to watch, to get insight not only into individual men who've made great accomplishments, but also into an entire industry. And certainly with tonight's program, we continued that look into what really has been a kind of history of interventional cardiology, combining a kind of rigorous intellectual honesty with a true clinical genius. John Simpson has been a seminal influence on this industry for a very long time, beginning with ACS over 20 years ago, nearly 20 years ago, and continuing through a host of just remarkable companies since then. John has cast a wide influence over both this industry and this clinical specialty. And the presence of just a remarkable group in this audience today, I think, is a testimony to the influence that John has had. One of the other things that we've actually explored, that we have also explored in this series, has been the interconnection or the interface between entrepreneurship and clinical practice. And lest you think that there's a kind of model for physician entrepreneur, I think this series has proven that, in fact, they're quite different. And I think one of the most interesting takes on that is John Simpson, kind of the reluctant entrepreneur, if I can characterize it in that way. So let me begin by welcoming you, John. Thank you for coming here today.
Thank you, David.
Talk a little about your early training. You were raised in Texas, and your first goal was not to be a doctor, an MD, but really to be what?
Well, that is correct. Actually, I wanted to be a veterinarian. And I was a pre-vet major at Texas Tech. Many of you may know that. No, nobody knew that, right? So I've been keeping that a secret for a long time. That's the first disclosure that I was a pre-vet major at Texas Tech. Struggled a little bit academically, didn't make it to class quite as often as perhaps my parents had hoped in the early days, and really found that I actually was not qualified to go to vet school when I finished. So I had to go to medical school, which was the next
Well, you didn't even go to medical school. You went to graduate school and studied.
I did go to graduate school. I studied the mechanisms that will allow a mammalian pregnancy to avoid immunologic rejection, in that a mammalian pregnancy is a foreign body and should be rejected, and we can go over some details about that if you want later.
Maybe we should just get right into cardiology.
But if you do take fetal skin and graft it to the mother, it is rejected in about 2.5 weeks. Just to sort of keep that in mind. That really, nobody really is too interested in that, David. I don't know how that happened.
That's not going in the right. So, but you went from there into medicine. And who was Bernard Amos, and how did that help steer you into medical school?
So Bernard Amos was the kind of premier immunologist at Duke University at the time that I was going to medical school. Had discovered the early, I think maybe the first histocompatibility antigen in man that was responsible primarily for graft rejection at that point, and was an extraordinary individual, and actually kind of helped because of my interest in basic science, had helped sponsor my application. And trust me, my application needed a lot of sponsorship, and Bernard was the special person in that regard.
And so you went from a PhD, you have a PhD in immunology, is that right?
That's correct.
And but you also have an MD. How did you get into cardiology? Why did you choose cardiology?
That's a good question. I think that cardiology for me, I trained at Duke, and cardiology for me was a kind of an area of special interest. I'm not really certain exactly how it evolved. It was not by default, although originally I was going to be an oncologist. Well, that was after vet school. So you can see I've had a very direct course, a very focused individual here, always on target. And after oncology really didn't quite gel for me, and ended up really seeking out cardiology, not at Duke, did not train as a cardiologist at Duke, did my house staff training there. I came to Stanford for my cardiology training.
Mm-hmm. Well, it's interesting because you've been such an important player in shaping how cardiology has evolved, the practice of cardiology. What was cardiology like in the mid-70s when you were training and were thinking about a career in cardiology, what would you have done had you been a cardiologist?
I mean, that in the early days of, in the early 70s, let's say, everything was diagnostic cardiology. So the whole concept of interventional procedures really was not very well formed. In fact, it was not formed at all, as I recall. And in fact, I was censored by one of the cardiologists at Duke when I was a house officer for giving a patient who was having chest pain nitroglycerin, because he could be having a heart attack, and that'd be very dangerous to do anything to anybody while they're having a heart attack. You could really put them at risk. He would struggle with our current approach to the treatment of acute myocardial infarction, where if you don't do something, you basically will go to jail. So it's a stretch, a wide departure. Currently, the therapy for acute MI would have never been imagined in the early 70s, I would say, and it's really to Andreas Gruentzig's credit that we end up with any interventional opportunity. That was really his domain.
Because as I understand it, you were not particularly inventive as a kid or as young. I mean, did you create things? Did you invent things? Did you pull clocks apart and put them back together?
Never did. Never had an interest at all. Drove a tractor, pretty good. Invented ways to take out some of my grandfather's cotton in ways that he was not totally approving of. But I know Tom Fogarty has given a talk here, and Tom is the ultimate tinkerer, inventor. That just really was never my strategy. Like machines, but usually big, a lot of wheels, and on the farm. So that was kind of the extent of what I did. Yeah.
So your goal, in fact, was always to be a practicing cardiologist.
Absolutely.
And you almost became one in Jackson, Mississippi. Thanks
to Jerry Griffin. Jerry Griffin is known to many of you here, and Rich in particular. But Jerry Griffin trained about the same time that I trained at Stanford. I was having trouble getting a job when I was finishing Stanford, and Jerry Griffin said that he knew somebody in Jackson, Mississippi, and they had an opening, and I took it. That was pretty much my only option. A little bit like vet school at the time, Nobody's really jumping out after this opportunity here, so.
But you never quite got to Jackson, Mississippi. Why didn't you?
So I sat through a presentation at Stanford. I'm sure Rich must have been there, and Don Harrison had invited Andreas Gruentzig to come give a talk, arranged through Richard Myler, I think, at Stanford, and to talk about this really neat thing that he had, where he's going to put a plastic balloon catheter into people's coronary arteries and blow it up, and it's going to make them a lot better. That seemed like a stretch. Sort of, for sure, a stretch. Huh?
No pun intended.
No pun intended.
What was your first reaction to both Gruentzig, both as a clinician and as a person?
Oh, I idolized him as a person. We had somewhat of a competitive arrangement, at the time, because I had sort of taken one path and he had another path. Remarkable individual, absolutely one of the most amazing people, very honest, I thought a lot of integrity, hard-nosed about good science and good clinical trials, strongly committed to his patient population, and gave great presentations. These kind of events make me a little nervous. He would have loved it. He would have just, the stage was Gruentzig's ultimate domain. He just would, he had a very, very special knack for that. And when I heard his presentation at Stanford, I thought that it was really quite a remarkable presentation. I was a little not quite clear on the clinical relevance of this balloon angioplasty procedure. And in fact, I remember telling my wife, and many of you have heard this story, this is absolutely true, that I told her that I had heard that day perhaps one of the most remarkable presentations that I had ever heard in cardiology by this guy Gruentzig, and that he was either going to revolutionize the treatment of cardiovascular disease or he was going to jail. I favored jail pretty much at that time. It made no sense to me that with any likelihood that you could take a balloon catheter and put it into a critical vessel sustaining myocardial function, inflate it, and then suddenly everything is just kind of going to be okay. It just didn't really quite do it for me.
And you had to go back to your colleagues at Stanford and kind of brief them on what you had heard. Did they share the same view? Was everyone as skeptical as you were about?
I think in the very first presentation, I think all of us were somewhat suspicious. that angioplasty, that's really, I don't think anybody really had a lot of confidence that angioplasty was going to go anywhere. I think Andreas had treated 5 or 6 patients intraoperatively at St. Mary's Hospital up in the city at the time. And they would go in through the site, the arteriotomy, to put in the vein graft, and they'd go back up retrograde and inflate the balloon blindly. And then Andreas told us that after he did that, that the flow was a lot better. Okay, good. But I mean, how would you ever do that, through the groin? I mean, it just, it did not compute at that time.
So what was the epiphany? What made you go from being skeptical or doubting about what Gruentzig was talking about to saying, you know what, I think that might work?
Well, we had a procedure several months after Gruentzig gave his presentation at Stanford. I remember vividly that Dr. Wexler and I was in training at the time, and we were doing a routine coronary angiogram, and we managed to lift up a plaque in the left main coronary artery with our diagnostic catheter, and ended up inducing a fairly large myocardial infarction in this patient. It just seemed like that the way the plaque had been dislodged, that if we had one of Gruentzig's catheters, that we could go in and push the plaque back up to the surface of the artery, and perhaps the patient would have not sustained the damage to the heart muscle that was sustained through our intervention. So I approached then chairman of cardiology at Stanford, Don Harrison, and asked him if he would be willing to send me to Zurich in the winter to learn. See, you all are thinking the same thing. See, that's not good. That's not good. And
Right.
Amy was laughing the most over here. I could hear it right off the bat. So, and he said, winter in Zurich to learn about a new procedure, I don't quite get it. I'm not going to pay for it if you go. So I did want to go badly. So I borrowed $500 from Bank of America, bought my ticket, and went to see Gruentzig along with Richard Myler. And Simon Sturcher had been there the week before, and Richard Myler, and we saw the most remarkable thing, because Andreas Gruentzig in Frankfurt actually put a small little balloon catheter up through a guiding catheter out into a right coronary artery, and what happened to be a very, very tightly narrowed coronary artery with one balloon inflation, probably at that time to some trivial pressure, maybe, 50 PSI, probably, a third of what we would use currently, it's just like the problem went away. And then I said, maybe this could be really, really good. And it just seemed like that if, in fact, you could routinely go into the human coronary space with a device that would push this plaque to the side, if it would work the same way that it had worked with Andreas' patient on that particular occasion, then we had stamped out all heart disease, just gone away. Unfortunately, did not quite work that way, but it was absolutely one of the most, I can still remember standing in the same lab. I've been back to that lab twice just to kind of check it out. Martin Kaltenbach was the professor who was really in charge of the lab. Absolutely a remarkable and special event, sort of transforming, my perspective on the treatment of cardiac disease, far removed from giving a nitroglycerin to a man at Duke with chest pain and being scolded for that, to go, and now then, not only this, but now then we are expected to, can you imagine coming in with an acute MI at Stanford Hospital and they give you nitroglycerin and send you to the CCU? I mean, you can do that, but boy, that's going to be an unpopular therapy. And most unpopular, of course, with the patient. I mean, that is just not the way the disease is treated anymore. So Andreas Gruentzig, I think, by himself, just totally revolutionized the space. I mean, he made it possible for us to have this meeting today, which is still kind of shocking. I'm surprised anybody came to this. I think you all must have a bad fever and you should have been checked at the door. Most of you have already heard all this too. See, I'm at a real disadvantage. Let me just be honest about this. I'm at a huge disadvantage tonight because I know all you guys, and all you guys know me. So most of you have actually heard.
We've got the checks at the front row here. If you see any grimaces, we're going to know that.
I've got some stories that are
you're not
for these guys
exactly
too.
right. But at some point, you went from being a disciple of Gruentzig, somewhat convinced that he was on the right path, to what you've described as an adversarial relationship. Where did you begin to say, that's right in most part, but there's got to be something else here?
Well, Andreas had a catheter system that required a lot of finesse to use it, a lot of talent, and it was a fixed wire system, and it was very, very difficult to use. And he was very special. He had great hands, he had great vision, he had sort of a 3D perception of where things were, but that was not going to work for most of us. And but although I did order that catheter system from Andreas, and I got everything that I needed with the exception of the balloon catheter, was the only that was left out of the kit. They were in short supply. And so without the balloon catheter, it was somewhat of a disadvantage, so we started putzing around with local plastics to see if we could make a balloon catheter of our own. At that time, Ned Robert, who was one of my colleagues at Stanford, a fellow in training at Stanford with me, agreed to pursue this bizarre path together. And so we started working on catheters solely out of desperation because we did not get one from Andreas. Had Andreas sent us the balloon, none of us, well, I wouldn't, you guys might be here tonight. I guarantee you, I would not be here.
And this is going to lead us directly to ACS. But before we get there, what was your reaction when Gruentzig died?
I was shocked. I was shocked. I was shocked, and I was really angry because we at that time we were somewhat a little bit adversarial, but I mean I had some new stuff too, and I was going to show him it was going to be better than his stuff, a lot better. I mean he wasn't even competing anymore, is the way I looked at it, and I just felt like that I had been cheated out of an opportunity to kind of continue this exploration of the, I don't know, it was really Carl Simpson. I don't know if Carl's here or not. Carl's the one who called me and told me that Gruentzig had died in a plane crash. And I just thought,
and this was something like about 6 or 7 years later.
After we started the company, yeah.
It's funny because both today and in a previous discussion, you characterized Gruentzig as honest, aggressive, hardworking, demanding, thoughtful. A lot of adjectives people used to describe John Simpson.
Well, those are exaggerated if they're used to describe me. If they describe Andreas, they were all very accurate, very accurate.
Okay. Well, you began with Ned Roberts, and I know that Ned was critical to the launch of what became ACS. In the early days, as I gather from you, you weren't necessarily thinking about creating an angioplasty company. You were simply trying to develop some tools. And I know you ran into a lot of troubles getting those tools, particularly the balloon early on. Talk about what you and Ned were trying to do in those early days and what you were forced to resort to.
Well, our goal was really to do something that was scientific and help characterize the events that surround angioplasty from a tissue perspective, let's say. And we'd worked with Don Harrison was interested in the study at that time and had arranged for us to use the Stanford alliance with NASA down at Moffitt, and they have a really nice animal lab down there. So we could go down there and we could test balloons to see if we could perform stretch injury to the coronary arteries, really kind of what happened histologically. In order to do that, we had to have a balloon to perform the stretch injury. And that was the balloon that we made on our own solely for the scientific study. This was not two visionaries out to launch a startup to do something really extraordinarily special. We needed 3 catheters to go to NASA and to test them in one baboon. We did that baboon in, unfortunately, with 1 catheter, which was disappointing to NASA, and they said we would not be seeing any more baboons at that point.
You were killing off the baboons.
That was, yes, that baboon had been smoking for 6 years and from Brooks Army Air Force Base and been eating peanut butter all day long to develop coronary disease, of which that baboon had no coronary disease. But they did not intend to lose the baboon in one of our studies either. So that study was cut short. But we did make about 3 catheters, and we ended up using them in animals. And then decided maybe these catheters were easier to make, and maybe they even worked and could be used more easily than Gruentzig's system.
Was that really what led to ACS, the realization that there was a simpler way, a better way to really design the guide wire and the catheter?
Well, we thought so, but this was prior to ACS, and at that time we were also...
So you even formed ACS at this point?
We had not formed ACS, and we were eager to sell this technology to anyone who's willing to buy it. And in fact, we presented the technology to USCI. USCI was a huge catheter company at that time, and really excited to make our presentation, flew all the way back to the East Coast. We gave our presentation. They said, you know what, this is kind of a small group. Tell us everything that you've done, and we'll tell you everything that we've done. You know where this is going already, I'm sure. So I spent an hour and a half talking to them about the way Raychem did our extrusions, about how they extruded the plastics, cross-linked the polymers, did all this kind of stuff, you know, hour and a half, that's great. Dr. Simpson, that's just wonderful. Thank you for telling us all this. And I said, and what have you done? And they said, actually, we haven't done anything yet. So this was my first introduction
to business ethics,
to the real world. And this was very, I mean, I was going, I thought, But I did not make that mistake again. You know, I'm not real quick, but, you know, 1 or 2 times like that, and you pick up on it.
So 2 weeks later, what did USCI do?
They signed an agreement with Andreas Gruentzig to buy, sell, and market the Gruentzig angioplasty system.
So it seems to me a lot of guys in your position would have just turned tail and gone away and said, this is really not for us. But you persevered and eventually formed ACS. When did the idea that you were going to create a company occur to you and Ned?
Well, I think, I'm not sure we had it at that point. The guy who convinced us that we could form a company is sitting over here.
Talk about your first meeting with Ray Williams. Where did you meet him?
So Ray Williams, and all of you know Ray Williams, I'm sure, but he's an extraordinarily special guy. But when I met Ray, he was dressed up in a set of dungarees, and he was parking cars for the Tally-Ho Horse Show at the Circus Club in Menlo Park. And Ray did not look like a real kind of a guy that you want to take your favorite catheter to and have him develop. In fact, I think Ray may have looked like the reverse of that at that point. And Ray said, oh yeah, Harold Hobach had mentioned, and I think Casey maybe got us in touch with Harold Hobach. And Ray said that Harold had talked to him, and he said, you know, I can really help you form this company. And I looked at Ray and his dungarees and the dust all over him in the parking lot, and I'm thinking, Ray, I mean, you may be a nice guy, but I'm telling you what, you're not going to start this company. I mean, I need somebody with vision, with charisma, you know, with money. I mean, come on, Ray. This is just not going to work. And Ray, I don't think I called you originally. No, I think Ray called me about a week later and said, you know, you never called, and why didn't you? And by then, I was starting to get the drift, though, that Ray was not a parking lot attendant. And some of my colleagues had informed me that that was just all a facade. So that really began a very special arrangement. Ray formed ACS with he and his 4 buddies. It took you 20 minutes to raise the money to start it. I was in his office. He was on the phone. He called, I don't know who, Gene Amdahl and Al Johnson and I don't know, 3 or 4 more guys. And next thing you know, they've raised $500,000. And I've never seen and or heard of $500,000, nor had I heard of venture capital at that time either. So the whole thing was kind of new to me.
So that was the beginning of ACS. I mean, I know that you had spent a lot of time trying to develop the balloon and trying to get exactly the right balloon technology, but the real innovation of ACS wasn't the balloon per se, it was the over-the-wire catheter. When did that occur to you, and what was that ACS's real fundamental success?
I think the over-the-wire angioplasty system was the thing that separated ACS originally. Eventually it was copied by USCI, but that was the original differentiating feature. And that grew out of my training with Lou Wexler, who's a radiologist at Stanford. And I mean, everything that we did it over a guide wire. I did not know that you put catheters in and did not use guide wires. So it was incomprehensible to me that you would not do angioplasty over a wire. And people say, well, gosh, how did you think of that? I didn't think of that. It was just a given. You had to put the system in over a wire because that's all I've been trained to do. Wexler didn't teach me to do anything else, so I was stuck with over the wire. And then we had to build a system around that, and that was kind of the ACS device.
There are, we've talked about Ned Roberts, who was your partner at Stanford, and Ray Williams, who was an early founder. There were a couple of other people who were critical at early junctures, not all at the beginning, but at various points. Let me give you a couple and just describe who they were and where they came from. Carl Simpson.
Carl Simpson, my great-grandfather, Carl. Yes, well, you always like to work with relatives, and so I wanted to bring Carl in early because, it's limited time for Carl. Carl's not even here. I mean, I had that line planned just for him. So we spent several years introducing each other to other people as our father, but I really wanted to put a stretch on it today, and I thought great-grandfather really would really kind of do it. Carl was special. Carl was the guy that was the lead technician in the cath lab. And he would come in and as cardiology fellows, we relied heavily on the nurses and the technicians to tell us what we were doing and putting in Swan-Ganz catheters. And Carl was the best. And he said, okay, well here, I think you ought to change the catheter. I think you ought to push it here. You got to do that. I mean, he would basically put in the catheter pretty much for us in the first 4 months of the training program for all the emergency catheterizations. Really special. Then he left Stanford and started to work for Hewlett-Packard. And then when ACS started, and I think Carl may have had a business degree thrown in there somewhere. It's never very accurately reflected in anything that he does, but he's with the Vertical Group or something now.
Versant.
Versant, sorry, Versant. Was that a slip, Casey?
We can edit that out. Will Sampson, who's sitting here in the front row, who came from USCI, if I understand that correctly.
Dave Prigmore. Yeah, we kind of stole. I'll be honest with you. We did steal Will from Dave Prigmore. Dave Prigmore was not the guy that told me they hadn't done anything. That guy was some other. Remember his name? Shepherd. John Shepherd. Yeah. He was the one who told me that actually we haven't done anything. So, but while we were there, we did meet, and we met Will, and really kind of stole him away from the East Coast, moved him out here to all this bad weather, and it's really kind of a take. Will, as always, I've got a few stories about Will. The only one that's really important is that Will did fire me from ACS. And about the, see, I told you I wasn't going to hold back tonight, now, right? He said I was an overpaid consultant, and they kind of terminated my arrangement with ACS, but Ray Williams' credit, he reinstated me. And trust me, Will Sampson was correct. I was definitely overpaid for what I was doing at that time for ACS.
And then Bob Reese, Ray brought in Bob Reese at one point to really...
Bob Reese, the only thing that I could say negative about Bob Reese is that he did have a tendency to smoke a few cigarettes. I don't know if any of you guys have remembered that about Bob. Hopefully he stopped smoking by now. But a real visionary, and he came in to run ACS and to really make it into a genuine company. I thought did an extraordinary job doing that. And it really worked very closely with Carl Simpson. So Reese was really an extraordinary individual.
One of the things that Reese, one of the experiences or one of the areas of expertise that Reese had was in manufacturing. And it seems to me that complemented nicely your clinical background. I mean, obviously there would be no ACS if you hadn't had the clinical insight to develop the technology, but there was also a manufacturing issue and an engineering issue around the early ACS device. Talk a little bit about how important it was to find someone who could help you engineer and actually manufacture these devices. Was that something that you got actively involved in, or was that something that you left to others?
Oh, no. I did not do any of the engineering, and in spite of what Will Sampson would say, I didn't even try to interfere with the engineers, although that might be alleged. I totally knew my limits, and that's, to be honest with you, I have to say one thing about John Simpson, third person, it kind of separates it out there a little bit. He does know his limits. That's probably the one thing that has made him, I think, a cut above some of his colleagues that do not know their limits. And I've always made it a goal to surround myself with people that are a lot smarter than I am, as in these first couple of rows here, because I just felt like that as a part of a team, and this is legit, I mean, this is really real. I do believe that it's always a team effort. The whole concept that there's some special visionary out here and that if he does all this stuff, he or she by him or herself, that is flawed as far as I'm concerned. It's putting together a group of individuals that make a real genuine contribution and can work together to develop something that is really special, that makes it truly unique. And it takes a huge amount of support and funding from people who have enough vision to put the money behind it. And then it takes the engineers who have to be willing to give it a try. They have to be willing to persevere, they have to stick it out. I think this is really a hard job. It's really, really hard. I know that there have been people who allege that, there's like, yeah, you're walking down the street and people have had these visions and suddenly the design of a catheter pops into their mind and they make it that afternoon and then the following day they achieve enormous wealth. I keep, every morning I get up, I check my mind to see if it's in there, and if it's not, then I go to work. And so far I have not missed a day of work because of one of these special visions. So I think it's a lot about perseverance, a lot about the teams, a lot about the organization, engineers that are really, really, really smart. And they may not have all come from, from the medical device sector. I mean, well, first of all, there was no medical device sector when we started this, just period.
Right.
I mean, Hanson, you did like some electrical actuation mechanism for a landing gear on a airplane, or something. A nose gear. Come on, that's
Hanson Gifford.
Hanson Gifford. He's one of the partners in all of this mess. But you've got people that bring some commitment and some special willingness to persevere in adversity, and then you can make really special things happen if you stay focused on doing something really clinically relevant, not real big on fluff, something really, really, really clinically relevant, then I think there's a great chance. There's a great chance too, but it doesn't always work.
So let's go back to ACS for a minute here. You did your first patients in 1979.
Really? Wow.
When did you know the company was going to be successful, and how important to you at that time was commercial success as opposed to clinical success?
I don't think we ever imagined that it could be commercially successful. Ray Williams and Casey structured it all. Ray, I think, thought that it could be, but there were many times, I went into Ray and I said, Ray, our 10th patient, again, we closed the artery. The lady that worked at Nordstrom's, remember her very well, closed her LAD, big infarct. I told Ray, this ain't gonna work. I said, we have to take this material out. That's a separate theme. But Ray said, well, before we start taking it out, let's pursue the balloons a little bit longer. And Ray really had the vision to say, let's persevere. Let's keep doing this and let's find out. And I don't think by case 10 we had one success. From case 11 to 22, we had like 11 more successes. And all of a sudden it goes, angioplasty could work, it does work, we need a better device. This one isn't quite the answer yet, but let's persevere, let's work, let's change, let's iterate. Bob Reese is really big on you fail fast, this design, build, test loop, build it, test it, it doesn't work, build it, refine it, build it, test it, it doesn't work, and just keep doing it over and over and over again. And he taught all of these people. I see them all right down here. Ferrari, for sure. Ferrari's a bright guy,
Rich
okay?
Ferrari.
Yeah. But, definitely, you learn it by being involved in the team. Now, I'm sure there are some special visionaries, and I might even put Fogarty and Julio Palmaz in that domain. But for me, I'm not that smart, and it's got to be a team effort. A lot of hard work, a lot of perseverance. But you have to be able to persevere in the face of adversity. When we told people we're going to put balloons into their coronary arteries and blow it up and they're going a lot better, and a lot of them did not, those were tough times. Those were really tough times. There are patients that did not survive their intervention. If you think you get paid enough to do that very often, you do not get paid enough for that. And the whole concept that you do this for the money is absolutely, that is flawed. If you do it for the patients and it works out really well for the patients, you'll make a ton of money. And if you do it for the money and you figure you've got some, and it becomes a scam, then it is really going to be a frightening and long road. It will just absolutely not work. It doesn't work.
ACS was an interesting business story, in part because it was a tiny startup that quickly overtook one of the largest companies in the space at the time, USCI, which had the originator's technology, and then did a very interesting deal with Eli Lilly to sell the company. How actively were you involved in any of those business decisions, and did you find some fascination, or were you more than eager to push that off to others and say, you deal with those issues?
Well, I can tell you how involved I was because I knew that the acquisition was going to take place when Ray Williams showed up with the check. So we sold it. I said, you did? Good job, Ray. Good job. I didn't know you could do that. I mean, how does that work, you know?
Where'd that check come from?
Who bought it? I mean, Eli Lilly. Eli Lilly. I mean, I thought they made aspirin or something. I mean, what are they going to do with this? I was totally uninvolved, and Ray will tell you, since then, in other companies, I've been a little bit more involved in kind of the organizational issues, but not in ACS. I had no expertise, no experience, and no confidence. No, that would just not have worked. Ray wouldn't have let me either, so that was the good news.
Mm-hmm. So I described you before as a kind of reluctant entrepreneur. You said to me that you don't mind the title of entrepreneur, but you don't really consider yourself a businessman. But for somebody who doesn't really consider himself a businessman, you sure started a lot of companies. The next of which in the line was DVI. Where did the idea for DVI come from, and how did that get started?
I still remain committed to the concept that the material that's in the coronary arteries doesn't belong there. And the DVI was our first efforts to confirm that in fact was the case. Had Hanson stayed on and developed more product for us, of course, we would have been able to find out. But DVI was I think it's still a good device. It's just too hard to use. And ease of use is everything in this space. And we developed a device that would take material out of the coronary arteries. Thought that was very important. We still believe it to be very important, but we need a device that's easy and simple to use to accomplish that. And part of this plays off of our early discussions with Ray, where we said, there are other ways we think to treat this disease, and we think taking it out will be one of them.
Were you surprised, going back to ACS, were you surprised at how quickly angioplasty took off as a clinical procedure, how quickly doctors adopted it?
Oh, I had vision beyond belief in that era. And I'm actually quoted, and you can find this in the San Mateo Times, where they interviewed me. I hope they've burned the records. But they interviewed me in 1983, I believe, asking me to predict the size of the angioplasty market. And I said it would never, ever exceed 1,000 patients per year in the U.S. Vision. That's what we're talking about here, gentlemen and ladies, vision. My marketing sense is 1,000 patients per year. Next year, I think I elevated to 2,000 because we'd already done 2,000.
The reason why I ask that is because were you conversely surprised that atherectomy didn't catch on?
Yes, I was. I was shocked. All because of stents. Stents just absolutely blew atherectomy out of the water. Stents are so easy to deploy, and the immediate outcome is essentially guaranteed once the clotting problems were solved with stents. And I still think that taking it out is more rational, but we still need better devices.
You've never, in fact, you weren't really an early supporter of stents.
I'm not a supporter of stents today, so that's not you can tell that I'm still not a visionary, see?
DVI was the first kind of company that you kind of started on your own. Was it important to you to be more involved in the business issues involved in DVI? Why didn't you just do DVI why don't you just go to Lilly and say, here's an idea for a technology that I think we ought to develop as part of this package? Why did you start DVI as a separate company?
Well, we did. We went to Eli Lilly through Bob Reese. We presented the design of the DVI device. But large organizations do not like to buy risk. They like to buy cash flow. They like to buy a revenue stream, market share. And that's what Eli Lilly and Abbott and J.J. Ascorius, that's what they're all about. And it's not a very good place to go in and say, I got this really neat idea. What do you think we work together? That also is as flawed as thinking you can do just this without any clinically relevant impact. So Bob looked at it on behalf of Lilly and on behalf of ACS and said it was a little bit too early for them, and they elected not to do it at that time. So, you know, it took us, 4 years probably to get it to the point where we had enough function through the help of hierothapleol, where the devices were working well enough so that we had cash flow. Not profitable, I don't think, but we had sales, and that's what the companies always buy. They do not buy ideas. Large companies are awesome at taking something that's been fully developed and ready to really have impact in the market, and they'll drive it really hard. It's not the place for entrepreneurs to go to say, help me develop X. No, it's a little bit of my opinion. I don't know if that's true or not. But.
Am I right in thinking that your next company after DVI was Cevis, and you started working, as I understand it, with a young doctor at Stanford named Paul Yock around ultrasound?
That guy, I mean, what can I say?
What a waste. You were doing so well, and then you got involved with that guy. How did that work out?
I like to take credit for starting. Actually, I think I wrote the very first check that went in to see this. I didn't get that much back for that check. I need to start talking to Rich Ferrari over here, I think. Kicked me off the board, lost my money, I saw other than that. But Paul Yock was the guy who said, we need to image the vascular space. Eventually, we need to image the vascular space while we're working on it. And that was really Paul Yock who had that vision. And I would love to take credit for all the hard work that he did. I usually do take credit for other people's work. I've kind of mastered that, so, you know, but with Paul, it's too nice a guy, so I can't take too much credit there.
Mm-hmm. And visualization, we'll save it for later, but visualization will come back around when we talk about Fox Hollow at the end, but it seems to be visualization has been a theme since just post-ACS and DVI about technologies that are important to you in advancing this clinical practice.
Well, you really like to be able to see what you're doing inside the vascular space. That's pretty cool. There are other ways to do it. You can see it using fluoroscopy and X-ray imaging and things like that, but there's a special visualization with ultrasound that is more precise, more direct, and when we can perfect it, which is close, it will be special, I think.
Within a couple of years after that, you launched two companies fairly closely together in time. One was LocalMed and one was Perclose. What was LocalMed's technology and what was Perclose's technology?
LocalMed was one of our best ideas. Keep this in perspective. It was really, really, really a good idea. We need to put medication into the arterial wall that will suppress cell proliferation, as in the drug-eluting stents.
That's right.
Okay, so we knew that. We knew that like 10 years ago. And we actually developed a pretty good device. We had no drug. Do not ever develop something. Do not ever build a really nice gun for which there are no bullets. That also, see, I've introduced you to a lot of flawed concepts tonight. I have a lot of those to talk about. And LocalMed was really a great idea, but it turns out that in the end, we did not have the drug to deliver. And we had a delivery system, but nothing actually to deliver. And Perclose was kind of the stepchild company at the time. You know, it's a little device to remotely close the arterial access site that's created during an intervention or during a diagnostic procedure, and everybody said, oh, what's that going to all amount to? Well, it's really important to patients that are anticoagulated because it really helps reduce the bleeding complications associated with arterial access. So, I mean, it was really extraordinarily special, and I see a whole bunch of the Perclose people here as well, and they should be credited with a lot of work, but it was thought to be the company that would, unlikely that was going to be a big hit. LocalMed, whoa, that is going to just really knock the socks off of everything. So, you know, 5 years later, LocalMed declares Chapter 11, and Perclose sells to Abbott Laboratories for umpteen gazillion dollars. I don't even know what the number was, but
$680 million.
$680 million. That was good. That was a good transaction.
So did
I approved of that one. That was good.
I know you're proud of your visionary status, but did it give you any thought about the whole process of serendipity and unpredictability in the design of medical devices?
This is so hard. I tell you, I'm very serious. I think this is a hard space. It's extraordinarily rewarding if you persevere and you do it right, and you keep the patient in front of the vision. You deviate from that and start to get kind of tricky and a little slippery. Just doesn't work, and it does require good fortune, timing. You know, atherectomy. You know, 5 or 6 years before the stents came out. Could have been really good. Right when the stents come out, not as good, kind of thing. So timing is a lot, yeah.
LuMend was your next major project, and that's a kind of work in progress, although the product's now approved and doing well in the marketplace. What was LuMend designed to do?
Yeah, LuMend is a device that opens chronic total occlusions, and I think I talked to Matt Selmon last week, and they just opened their longest standing chronic total occlusion, 21 years. This vessel documented to be closed angiographically, that they were able to open up. It had two previous bypass grafts placed in this particular artery. And I don't know, I think it's extraordinarily special. A little bit tricky to use right now, which makes me a little nervous because of the same experience that we had with DVI. But they have absolutely performed some miraculous events for opening up arteries that patients never ever thought that they could have access, you know, to flow in those arteries again. Really, really, really extraordinary. Technically a little challenging. It's sort of a Pac-Man in reverse. It's just put it in the artery, and you open it up and go down through the area of total occlusion. It can be pretty special. Not quite as predictable as we would like right now, but good.
You know, if you put all these products together, they seem to represent a kind of suite of cath lab products, but I know in the past you've told me that you don't really see the kind of arc of your career creating a kind of cath lab armamentarium. Is there a common link between all these projects and all these technologies for you?
Well, I should say that Matt Selmon is the founder, and he's the visionary behind LuMend. And it was really his idea. He's always been interested in chronic total occlusions, and that was really his thing. And I helped finance a little bit of the early going with LuMend. But yeah, I think that this is not an attempt to globally corner the market on devices. But I think that if we see an area that we think, chronic total occlusions are really important. And if you could find a way to fix that, and many people have tried, then we should try. We like to do that kind of stuff. And when I say we, I say collectively the investors and the engineers and the physicians, and that must be 100 people that are pretty much involved in it from the early going.
To go back to your early experience with USCI, after you approached USCI, did you approach any other product companies about either buying what you had designed at that point, or helping to fund or move the project along?
I've never had too much success with large corporations buying and or funding something in the early phases. We did take ACS to Bentley Laboratories also. Also took it to Datascope, Bentley Labs, and USCI.
All of whom said,
Datascope went out on the limb and offered us $20,000 cash each. Ned got $20,000 and I got $20,000. And then we said, actually we thought that might be a pretty good deal for the ACS balloon at the time. None of them had worked, so I mean, why not? Bentley Labs offered us 100, so they had stepped it up a little bit. And Ray said we could do a little better than that, and then he took over. So that was the kind of the special part of that arrangement. My experience with the whole business side of things, though, it really, I relied heavily on Alan Will for the DVI transaction, Hank Plain for the Perclose transaction, Bob Reese for ACS. It's that part is a little bit out of my domain. I can certainly tell you, really, I think very accurately if it's working well for the patients. I think that's my strength.
Because you've been associated, at least in the minds of many in the industry, with two companies primarily, Lilly early on and more recently Abbott. But it sounds to me as if that's more coincidence than anything else. I mean, maybe more driven by the big companies than by your special relationship that you have formed with those companies.
Oh yeah, no, I have no real relationship with those different organizations.
More recently, you've also been gotten involved with a venture capital. I know one of the issues that we've explored in the series is for the young, calm entrepreneur, calm an innovator, someone with a new technology idea, funding remains a critical issue. You fortunately found Ray Williams at a critical time for ACS. Why did you form a venture? Why did you get involved with Novo Ventures? And what is, to your mind, having that affiliation with a venture capital firm do for you now?
Well, since I started off not even knowing what venture capital was when I met Ray and Casey, we have become totally dependent on the venture community for funding for our development work. But if you think you can fund this stuff at the corporate level, I think that is early on. I mean, you can work out partnerships later. I don't think those work either. But early on, your only option is to fund this from the venture community or angel investors. I mean, Ray also has some other, but it's that same group, whether it's venture or angel in the very early days, that has to fund. They're only the ones willing to take the chance because they get enormous returns occasionally, but not every time.
You know, you started ACS working out of your kitchen,
My den.
Out of your den, driving your wife crazy with the smell of that. And now you must have just tremendous resources available to you when you want to start a company. How has life changed for you? Does that make the ultimate success of the project more guaranteed when you've got those kinds of resources, or is it still a serendipitous process of an elusive endpoint?
It depends on how much you can do something that's special and help the patient. I mean, when we finally develop a device that cleans out coronary arteries while you visualize and see what you're doing so that you can't really create a problem, then stents go away.
Which you think is, which will lead to Fox Hollow. Before we talk a little bit of Fox Hollow.
You guys were late on that one, I tell you. That's good, exactly. They do go away. Stents are going to go away. It is the wrong thing to do to put a piece of stainless steel, wedge, mesh, anything in your coronary vascular space with a cytotoxic agent on it and kill all the cells in the vessel wall. Bizarre. Totally bizarre.
Sounds like
and you heard it here, too, I'll tell you. You should have cut me off early. See,
Someone I spoke to called you the most intellectually honest person I've ever met, ruthlessly honest, particularly from a clinical point of view. If something doesn't work clinically, he'll pull everything apart no matter how far down the road, even it would be embarrassing to someone else to admit their mistakes. Do you agree with that characterization?
That might be the first really honest thing you've said tonight. Yeah, you know what? This is where you win. It's where you win. I mean, you fix the patient and you win. You don't fix the patient. And the other thing, if the device isn't working and you say, you know what, that must have been a problem with the model. It must have been the patient. The narrowing must have been too tight. The cholesterol must have been too high. The humidity must have been bad that day. You come up with a lot of excuses. It's because the thing didn't work, and you better fix it. And if you fix it, you win. And if you pretend that it was some other problem, you lose.
You know, what's interesting, if you think about it, I mean, having one successful company, had you stopped at ACS, you'd be a legend in this industry, but the string of companies you've had since then has been truly extraordinary. And yet you speak for such an integrity about the companies you create. Have you ever had to compromise the clinical vision for a business consideration, for a business success? Have you ever had to do anything you didn't feel like you should have done clinically because the company needed to do it?
Well, you know, I don't think that I have ever had to do that personally, but we've had arguments within the organizations about, you know, should we put an antibiotic coating on the suture to reduce the risk of infection below 1 in 1,000 where it is now to maybe 1 in 5,000? What will it cost to do that? how will it be implemented? Who will do the testing? How will you know? Since that was Michelle's job, I see her nodding her head back there because, there are issues. There are some things that are not very clear. And you like to think that everything is really, so when it gets really unclear, then I suppose that's when there's debate. If a device is coming apart in the patient and patients are being injured, it's not unclear. And that's where I kind of lose it. The nose cone comes off of a device, and the surgeon has to go in and take it out of the left anterior descending coronary artery. It's not very confusing to me. That's not working right. We need to fix that. We need to fix it right now. I think that, and to be honest with you, maybe it's the companies that I've worked with, maybe it's Abbott or Lilly, but I don't think they've put me in the position where they said, look, we can't afford to make the best product here. We're going to have to make kind of a medium-range product because it's going to be too expensive to make it right. That hasn't happened to me yet. Maybe it's happened to other people. I don't know.
Your latest, we have just a couple minutes left, so let's talk about your latest project, which is Fox Hollow. It seems to kind of pull together a lot of themes and a lot of interests of yours, clinical and technology issues, over the course of the last couple of years. What is Fox Hollow trying to do, and where will its success lie?
On how well it can treat the patients, and particularly if it can provide a fairly simplified way of very predictably removing tissue from narrowed coronary arteries. I think we're making great strides in that regard. We get the tissue out, we get to study the tissue, we send it to Judy Swain, Tom Katermos. They get to tell us what the genetic expression is. There will be ways to characterize the disease process using the tissue, which we think will be really special. And it's easy to use monorail guide wire system that goes in, and we think that it's really special. Probably should have imaging on board at some point, and that continues to be one of our goals to incorporate imaging into that. I think you'll see more debulking in the next couple of years. And we've debulked some stents that had drugs on them, and sometimes the drug does not interact as nicely with the vessel wall as has been alleged, as imperfect. That also does not occur. So there will be situations where debulking, bifurcation lesions, high-grade osteal lesions, things where you would not like to put a stent if you could avoid it. I know that sounds really weird to you guys, that there's some place you might not want to put a stent. And I know it's a stretch. I know it's hard. But there are some places, and I think we can debulk those. But it will always be. I can remember Andreas Gruentzig when he was very first approached with the concept that now then you have stamped out bypass surgery. There will never be another bypass operation done. And Gruentzig just laughs. He has to hold his stomach. He's laughing so hard. He said, that's just not the case. This is about trying to continue to improve our technology and use it in the very best application that we can to really benefit the patients globally. And he wasn't exaggerating that. Bypass surgery, yeah, sure, I think it's flattened out. I think we can, if I have my way, it'll flatten further, I suppose. But there will always be bypass surgery. There will always be stents. There will always be debulking. There will always be drugs. It's really that we can use this magical combination of many things to the patient's benefit that keeps us all, I think, headed in the correct direction.
Finally, as you've, again, been a seminal influence in nearly a dozen companies, are there still ideas percolating in your brain? Are there still things you'd like to do as you look out and you say, gee, once you get Fox Hollow underway, are there still other ideas and other technologies and other companies that you'd like to
I always say no, and then something happens and I have to retract that. But I have to be honest, right now I'm really excited about my relationship with Novo Ventures and all the new companies. Immediately I send to them, and they're really good at just tearing these companies apart. Right? Oh no, that's not the right term. Put them together. But yeah, I think these guys are the ones that will sort of fund a lot of these startups. I enjoy working with the startups. I don't really have a plan to do another one myself. I may have had enough. Of course, every time I say that.
Well, John, I think I speak for everyone here, and I say even if you stop now, we're all in your debt. Thank you, John, very much.
Thank you.
Just a question about how critical do you perceive embolic protection to be to interventional therapies, and do you see a role for both proximal and distal protection systems, proximal maybe for total occlusion and distal for others?
Mm-hmm. Well, embolic protection is another thing that's here, and it is real. Anytime you have stuff breaking off the artery wall and going downstream, that's just always bad. You cannot have, and sometimes it's tolerated shockingly well. I think embolic protection is extraordinary. I would prefer proximal protection if I could have it, because that way I don't have to put anything across the vessel, or across the stenosis or the disease segments. And you know, you hear from the surgeons, they tell you all the time the disease is much more diffuse than you would ever predict from the angiogram. Guaranteed, they're right there. They're pretty much right every time. So if you could have proximal protection, I think that would be the most ideal. Distal protection, though, I think will work pretty well in a lot of settings, and there will certainly be anatomical situations, you know, carotids with very, very bad disease in the carotids, or vein graft situations where, and maybe even some very large native coronary arteries where distal protection is going to be really extraordinary, very important. I'm surprised still about how often you'll put in a distal protection device and you don't trap anything. I would think it was something that would come off every time. And then a lot of times it doesn't. And some lesions that look like there probably won't be much coming off of this lesion, you know, boom, you get a ton of stuff. So the whole concept that you can predict by looking at the angiogram and or ultrasound, I'll tell you, is also flawed.
Thank you.
You talked and you contrasted yourself with the previous speakers that we've had here, and that you don't see yourself as quite the visionary that the other speakers are. I was wondering, for those of us in the audience who may not also be visionaries.
And not everyone would agree with John about that.
Right, sure. Yeah, I was just wondering, do you have any advice for us as to how we might position ourselves to be in the situation where you found yourself, where you've put yourself in situations while not necessarily being the leader of certain things, but still putting yourself in the position to be at the top of many of these companies. How did that come about, and how would you advise some of us?
Well, I would say that you need to identify really what, from your perspective, something that's clinically very, very important, what you perceive to be clinically important, and that you find somebody in the medical community that supports that. But you have to be able to feel really passionately about it. You have to have trouble going to sleep at night, thinking about how we're going to make this device work or this system work. When you wake up in the morning, you need to be kind of thinking about it. And as you say, that some of the stuff's getting a little weird, but you really do have to be committed. So this is all about commitment and perseverance, unless you have the vision that Gruentzig had. But you know, to Gruentzig's credit, I mean, there were years that went by where he was relying also on his own perseverance. I mean, people laughed at him. He was kicked out of the cardiology division at Zurich. Why was he doing cases in Frankfurt? Because he wanted to go to Frankfurt every day? I doubt it. Martin Kaltenbach said, come to Frankfurt. You know, they don't like you in Zurich. You know, come over here. And that's a pretty common theme. And you'll have to persevere in adversity. That's the thing. And I think that's one of the hardest things to do. You always want to give up. And you think, are you kidding me? This is getting old, everything. And as soon as you do that, you've pretty much lost.
Did you almost give up with pre-ACS, with the new design that you wanted to do? Was there a point at which you said, you know what, it's not really worth, I got to go back and go to Jackson, Mississippi and cut this out?
I'm not sure that I ever thought that.
What did you ever tell those guys in Jackson, Mississippi? I'll be right there.
Yeah, I tell them every year, next year. I kept that job for 4 years. I never showed up. I never got paid either, though, so it was okay, too. But I would say that there were times with angioplasty that I worried that the device is not working well enough to have really the kind of impact on patient care that we want. And there were times with the angioplasty, you put the balloon in, the narrowing looks just like it's perfect. You put the balloon in, you inflate the balloon, you do everything just right. And the thing is dissected, torn up, closed, and the patient's in the early days, we only had bypass surgery, didn't have stents. So now then, here's a patient, now you've basically induced a myocardial infarction. It's just not fun. And you have to, and you just sort of think, oh man, is that good? And it's probably not good. And can we make it better? And you have to stay with it through all those tough times. And I think that's where, if I could credit myself with anything, I think that's probably my strength. You know the story about the tortoise and the hare, you know? My wife says that I'm a very slow tortoise. That's not a compliment. She thinks it's not, but actually it is. Because the reason that I'm pretty good is because I sit in front of a problem for a long time. It doesn't go away for me very quickly. A lot of people see the problem, boom, they're off, they're gone, there's some other deal. And because I move so slowly, and I just sort of plod along, I can kind of finally figure it out. And I'm kind of a hang in there kind of a guy. So if I had to give you some advice, I would say find a really good group to affiliate with, but be willing to hang in there in the face of adversity.
Great, thank you.
Thanks a lot.
Next question?
My question is in regard to the serial entrepreneurship that you've experienced, and what factors do you use to decide for yourself as a person, not necessarily as an organization, when to move from one opportunity to the next? Because in the current opportunity or your current business, you experience some success, and obviously you want to continue with that successful organization, continue working with the people that you have been working with. They value you as a team member. How do you decide that it's worth leaving that current opportunity for a new one? And then when you do that, how do you break away from the old organization cleanly?
Wow, so that's a complex question, I believe. And there might be several questions in there. You know what, I've never really, I think, had to break away from the old organization. I think I've stayed involved. I mean, ACS perhaps, not as much as some of the other companies, but I'm still involved with Perclose. I said I do not have an affiliation with them. I'm a paid consultant for Abbott Laboratories, so that was an incorrect statement. But, I think that the concept of staying involved that's a pretty easy thing to do. I think the harder thing to do is to see an opportunity and decide if you want to work on it or not. And I would like to tell you that I have this really brilliant formula for that, and I enter all the elements into this spreadsheet, and then I hit go and execute, and I don't get it. I have no idea. So something feels pretty good about, you think, if we could do that, that could be really, really special. I think it's more of a feeling. I mean, it's not I'm not very, I can run Excel spreadsheets now, as long as they'll fill in the formula for me, I can do that. But I rely a lot on just sort of my sense. I'm not sure. That probably is a lousy answer to your question.
Local med aside, have there been any technologies that you thought were certainly going to wind up embodied in a company that you just stopped at the last minute and said, you know what, this really is not worth pursuing?
Well, I always thought local was worth pursuing. I mean,
yeah, I'm saying, but when you got to a certain point, and you said, I've now invested 6 months in this, and I'm just going to drop this project.
I never have. I've never started something and in 6 months figured out the answer. People talk about that all the time. We're going to give this 6 months. My friend and colleague here, Dr. Mooney. I say 6 months. What will you know in 6 months? You can't know in 6 months. Oh yeah, we got it down. 6 months, then we'll know. So there's no chance that would work for me. It might work for de novo, but to me, it's you just go until you figure it out.
Great, thank you. Next question.
Thanks.
My name's Todd Britton. I'm a cardiology fellow actually at Stanford, and I'm just interested in finding out how you were successful at balancing your role as a clinician and innovator, and particularly in some of these early technologies when things don't go so smoothly sometimes, when the LED closes down, and where you find your role with patients. And obviously you've done that very well and been very successful, how you were able to do it.
Well, I think the balance is complex. It's kind of tricky. To be honest with you, in the early days, Ray Williams was one who helped me I mean, they provided me with a consulting arrangement at ACS that allowed me to stay at Stanford and continue to be a fellow in the cardiology program there. I think without that, it would have been very hard. I had 3 children at the time with a 4th one on the way, and my income from Stanford at that time was almost enough to pay the interest on my house, but not quite. So it left me with a slight negative, you call that negative cash flow? I forgot. Ray, help me out here, because I'm getting out of my space, as you can tell. But it was really a struggle, and I think that how you balance all of that, I mean, you need support from some other place. You're not going to, well, I don't know, you might get it from Stanford, but Judy's nodding her head that says, you know, I don't think Stanford has the capability of doing that. I think that's an unrealistic expectation of the university. So you'll need support from some other source, and then you need to balance your family life. And my wife would explain to you that I've done that perfectly. No mistakes in that space. So that's a very, very hard thing. I think that's a dilemma for all of us, though, right? It's not just the physicians. Physicians, I think the worst part that I ever experienced was having a really, really, really bad complication. And then, you know, and then having to go on and kind of pretend that, or not pretend, but kind of put that in the background and keep going. I take patient complications very seriously, as I'm sure everybody does. But I was thinking maybe if I had a weakness, it's that I was a little more affected by it than some. And I remember my first angioplasty death, I mean, really vividly. Just like, oh.
Didn't that lead to DVI, in fact, the first angioplasty death? Wasn't there
Yeah,
a
it
connection
did.
between the two?
Yeah. I had an angioplasty death, and I said, it's crazy. We got to take this stuff out. This is ridiculous. You know, we've got to get it out. And we started DVI. That wasn't the total answer either. Fox Hollow will be the total answer.
Thank you.
Thank you. Well, there are no more questions. John, thank you very much.
Thank you.
That was
Thank you.
great. Thank you.
Super. It was a pleasure. It was a pleasure.